Hi, my name is Richard Winder. I'm the principal of the Northern Health School, and my presentation today is talking about the way our school has changed and adapted to the changing environment in which we work. I'd like to start first of all with our whakatauki. Whakatauki is a saying or a motto, and most schools have one. This one was chosen with our young people in mind, and it goes, "Whaia te iti kaurangi, ke te tauhu koe, me maunga tete." And you can see the translation below. It references the idea of reaching for the stars as an English concept, I suppose. So what I'd like to do today is to talk about a little bit about our school, about some data about the young people themselves, the programs, the way treatment has changed, and how we are changing in response. So first of all, there are 3 health schools in New Zealand. There's a Southern Health School based in Christchurch, which covers the entire South Island of New Zealand. There's Central Health School based in Wellington, which covers the area that you can see in the triangle. And there's ourselves, the Northern Health School, which is based in Auckland. Our school covers 60% of New Zealand's population. New Zealand, like many countries, doesn't have an even spread of population. Roughly 500,000 students in the population. So our total roll reached 1,800 students last year, and we put through 3,000 students. So it gives you a little bit of an idea of the size of our organisation. We have teachers and students based in all the locations shown on the screen there. The column to the left are all the Auckland-based areas, and the rest, of course, provincial New Zealand, a whole range of other locations. We are still based in hospital locations in some places. The illustration there is New Zealand's only tertiary level children's hospital, which is based in Auckland and known as Starship. A number of our staff are based in community areas. So this is our Tauranga team. We have a large leased building where our staff are based. Increasingly, our teachers are based in local schools. So this is an example in Gisborne, where our teachers are based in a primary school, and from there they service the local area. So let's take a quick look at our learners. We have a series of guidelines for health schools that were set up in the year 2000 when the school was established and have been regularly reviewed since then. So in order to gain access to our role, you have to be a secondary school, have to be a school student, you have to be school aged. In New Zealand, we start at year 0 and the final year of schooling is year 13. You also have to be predicted or provided with a medical certificate by somebody specialising in the condition that the child has. The phrase is kind of loose on purpose. The idea is that over time, more and more young people are being treated by people who are not specialists in the pediatrician sense or in the psychiatrist sense. So we have widened the scope for who we will accept a medical certificate from. An expected 10 days off school with a hospitalisation is the minimum level, and that means that a large number of students going in hospital would not meet our criteria. 6 or more repeat admissions is the second criteria, and this would cover things like cystic fibrosis, where students go into hospital for treatment several times during a school year. And finally, a predicted absence from school of 40 days or more. All of this is predicted absence, so we don't have to wait until the child has had that much time off school. We just need somebody specialising in that condition to say that they're going to. One of the key features for us is that the students remain on the roll of their regular school. This means that the regular school is still funded for them, and it means that they have a place to return to once they are well enough to do so. So, what is our job? Our job is basically to continue their learning wherever they are. And as I said, New Zealand has quite a dispersed population. There are population centres, such as our larger cities, but a lot of people live in smaller provincial or rural areas. Our second major job is transition. And from our school, 80% are likely to return back to the school system in one way or another, whether their own school or a different school, they return to schooling. If you add in another 10% going into tertiary training or education, that brings it up to 90% going off to some kind of education. If you add in employment, then we're up to 95% of our students are transitioned into either education or employment. And you can see how many students left our school last year. So a little bit of data. If we have a look at the different health conditions that students present with, for ease of understanding, we divide our students into three different groups. There's young people presenting with a mental health diagnosis, an oncology diagnosis, or any other physical ailment of one sort or another that meets the criteria. From there, you can see that since 2020, there's been a 42% increase in mental health, and that's where our growth has been ever since the school started. There's also been a 10% increase in the amount of physical illness, and oncology numbers tend to remain fairly steady, roughly 100 students a year. In a New Zealand context, a student's ethnicity is an important area of reporting, particularly in terms of the government statistics. And you can see from there that European students in a New Zealand context, 75% increase in mental health. So like most of the rest of the Western world, mental health is a big issue for our adolescents, and that's certainly been reflected in our role. If we have a look at the year level of the students presenting on our roll, you can see there that from 2020 through until 2024, the actual numbers of primary age students have remained fairly consistent. The growth has all been in the secondary cohort. And you can see there that year 11, which is the beginning of our secondary qualifications years, 60% increase across that period of time. Let's move now to looking at who our students are. So I've put in a few real life examples. So we're talking about somebody with leukemia, 18 months of treatment, 15 years of age. Another example, a young person who's been in hospital for quite some time with kidney failure. Transplants of one sort or another are, of course, an issue that gets a lot of young people, gets people on the roll. Lupus, an example of a physical illness that's got somebody onto the roll. But as it says there, the vast majority of our students have a mental health issue, and often coupled with autistic spectrum disorder, neurodiversity, gender diversity, and so on. And generally, they don't like being identified in the same way that the other three students on there have been. And I think it's fair to say that our secondary education system can be quite aversive. And in some cases, you could argue it's the secondary school system that has made the students unwell. Whether that's to do with having 1,000 young adolescents all put in a school together, it is hard to understand why somebody would think that was a great idea. We don't do it with any other age groups in the same way. The effects of social media and so on have all been discussed in the literature well and truly. So how do we work with our young people? Since we started in the year 2000, we have started operating community support centres where the students come to us. These are small classrooms where students come part-time for maybe 2 or 3 sessions a week, and they can meet with their teacher and they can meet with other young people as well. Clearly, we work in hospitals, in the wards and at the bedside, and we have hospital classrooms in some places still. But most of what we do is we go to the student. We might meet them online or in person or in their school of enrolment as part of a transition back to school again. So the students program. All of our students have an individual program of one sort or another, and they vary hugely. The work that these young people are engaged in can be provided by any combination of our own teachers, the teachers from their school of enrolment, or our distance educator. And where they do their work, as I alluded to in the last slide, there are a number of places where they might be working. They might be meeting their teacher in a cafe or in a public hospital or in a public place like a library, for example. Most of our young people have a reduced curriculum load. Because they are unwell, the expectation is that they are spending a lot of their time and energy on treatment, and therefore they're not available to do the full load or full range of subjects that a well student might be able to do. Support centres have been a particular innovation from our point of view. Otherwise, many of our students are home alone. And being home alone as an adolescent is not necessarily a good idea for your mental health. Large secondary schools can be daunting places, and they may be the place where you became or first exhibited your illness. That may have manifested itself in terms of cutting yourself in the toilets at the school, or some incident in the playground, for example. Positive peer interaction is really important for any return to school, and having a small, confined, calm classroom can be a good place to start that process. And of course, there are logistical issues around this. Students who come to us free up teachers' time, free up travel time to spend more time with the young person. And of course, there are therapeutic and social and engagement benefits for our students. And we'll come back to the idea of engagement shortly. So that's a little bit about us. Let's have a look at changes in medical treatment. None of this will be a surprise. Drug and surgery improvements have been pretty dramatic over the last little while. We don't have students in traction anymore. They're more likely to be bolted together with titanium instead. Hospital stays get shorter and shorter all the time. For us, a number of Māori and Pasifika students have been traditionally affected by rheumatic fever, and it's an illness of poverty to a degree. In the past, treatment has involved lengthy stays in hospital where medical staff manage the students' activity and their treatment. That's no longer the case. Those young people are treated in the community now and spend very little time in hospital. When the school first started in the year 2000, by 2001 we had around 150 students on the roll. Now, fast forward to today, 1,800 students in 2024. Another example would be Taranaki Hospital. It's a small provincial town in New Zealand. When the school first started, we had a classroom in the hospital, and we would have had between 6 and 8 students there with a teacher and a teacher aide working with those young people. Now we're very likely to have no students in the hospital that meet our criteria, maybe one now and again. More centralised treatment has been certainly a factor in New Zealand. Treatment has moved to a smaller number of large hospitals away from small community ones. However, in Starship, our role has gone from around about 50 to more like 35. So the number of young people presenting in those large hospitals has reduced. Another interesting area for us is different forms of treatment. Māori or iwi-based treatment models have started to grow through New Zealand. Non-Western treatment models, if you like. And so that has had an impact on our role, and we have been able to modify our requirements to allow us to take up young people like that too. As in much of the rest of the Western world, our mental health services have been overwhelmed by the numbers of young people. So what have we done in response to all of this? Our role continues to grow, and it grows at a rate of about 10% per year, which clearly is a lot more than the rate at which our population would be growing. We've put a lot of effort into establishing bases or units close to where the learners are. So over time, we have grown our service, and we now have teachers operating out of 20 different locations across our area. We've also done some work to change the structure of our school. As the school gets bigger, as we have more teams and more units across the place, that's become more and more important. We now have an executive team made up of managers and deputy principals and a principal. We also have a strategic team. As I mentioned before, we have 20 different teams across the school. Therefore, there's at least 20 leaders of all of those teams, and trying to make strategic decisions with 20 people in a room, plus the executive team, starts to get pretty unwieldy. So we now have a process where 6 leaders are chosen from those people to be a strategic team for a period of 3 years. Each deputy principal has 7 of the school's teams reporting to them, and that gives us a way of making sure that we have some consistency across the school and that those teams have the support that they need. We also have a number of other teams across the school. We have a curriculum team, a wellbeing team, we have a cultural team, all of whom have specific roles within the organisation. Our change and development has also included focusing on the learner and developing what we've called a set of valued learner outcomes, which are these. Basically, engagement, well-being, and progress and transition are the key areas that we are talking about. We also have a set of indicators of how those students are making their own progress. Co-construction is a very important factor for us. The expectation is that every student's plan is co-constructed with the student, the parents, the medical team, and their school of enrolment. Monitoring and reviewing their learning, recognising when goals are met and being able to understand what the next steps are, regularly creating and reviewing goals, identifying barriers, and being supported by different community groups. We're also working very hard on a measure of engagement. According to the literature, education and health-wise, engagement is essential. We've been working very closely with a psychologist in our Tauranga area, and her work on engagement with students' engagement with their health program has been a catalyst to looking at engagement in their education program. There are strong similarities. We see it as a state of being, engagement, and also a process. And there currently is no measure of engagement as a process, and so that's what we're working on. Trying to understand the factors impacting engagement, trying to understand the relationship between health and education. And clearly there are times when a student's engagement in their learning is more or less evident. The more unwell they become, the more difficult it can become to be engaged. But conversely, the more engaged that we are able to be with them, the more engagement they have, the better their health treatment becomes too. And so we are working to develop an engagement tool, and the idea being that we will be able to report on that student's level of engagement, and as a school, be able to report on engagement across the school. We've also been building much closer relationships with iwi and local communities to improve equity. You've all seen the little diagrams that show a student who can't see over the fence and one who can by standing up, and you give them a box and they can see better, and so on. For us, Māori and Pasifika students often perform at a lower level from their peers. And part of this is to do with the way the education system works and social and cultural differences. So we're working very hard to understand better the needs of Māori and Pasifika young people in New Zealand. We've been working with a consultancy recently, and we've got as far as some work around structure and leadership within Māori society across our school, and building local community links with each of those groups, where our staff are connected well into the Māori landscape. Learning for the young people seems to work much better. Building our staff's cultural capability. There are many things that can make a huge difference when working with Māori and Pasifika young people. Some of those examples would be simple things like pronouncing a person's name correctly, understanding the protocols around going into a Māori home, for example. It's general good practice that you take your shoes off at the front doorstep, for example. And making sure that our staff have that understanding, have an understanding of Māori culture, have an understanding of Māori history, and some understanding of Māori language. We've also been working, as I said before, to review our guidelines for admission. We have changed those guidelines over time to reflect the changes in medical practice, as I mentioned before. We've also changed the way we operate in response to that health landscape. We would see hospital teaching as a legacy provision. It's still important. We clearly still have students who are in hospital, and some of them can be there for extended periods of time. But the vast amount of treatment required is in a community setting these days. Most of our mental health students are being treated in a community setting. And I guess my challenge to the rest of the world is to have a look at what is happening for those young people in your backyard? How is their education being supported when they are suffering from anxiety and depression and self-harm and so on? Thank you for listening to the presentation. Our contact details are on the board there, and I'll leave you with a thought from one of our young people about not being able to go back to school, but he went back anyway via the health school setting. Anyway, thank you everybody, and we'll look forward to discussing this with you in a few weeks' time.